Okay, so the attendee numbers are going up, and let's just give that a chance to settle in. We'll give it 10 more seconds. Okay, so welcome everyone. My name is Dr. Neeraj Mistry. I'm the Chief Medical Officer at the Fatty Liver Foundation, and we're really happy to have you here at our inaugural Live for Liver Health series. And Live, LIV, stands for Learn, Inspire, and Value. So while we do present this as a webinar series, it's actually more of an informal fireside chat type of format. And we delighted that for our first in this series, we have Dr. Alkhouri, who's joining us for this fireside chat. It's also quite an auspicious time for us to be talking about the future of MASH treatment and FDA-approved therapies, because if my understanding is right, 4 days ago was the 1 year anniversary of the FDA approval of Resdifra or resmetirom, which was the first treatment for MASH. And so it's an exciting time in the research and development for MASH, and we're delighted to be having this conversation. Next slide, please. As with all our webinars, here's our disclosure and disclaimer statements. The purpose of this webinar or fireside chat is to share information and to discuss what is out there. It is not a formal recommendation on any treatment for any individual, but whatever information you have or derive from this webinar, you're welcome to take it to your primary care physician, your specialist, and discuss treatment options. So this is about empowering our patient community so that they can have more substantive conversations with their healthcare providers. Next slide, please. So I often talk about how the liver is an organ that whereupon many other comorbidities in the body converge. And not only that, it's related to many public health, medical risk factors, etc. And so just looking at this, MASH is the 21st century looming public health threat because it is linked to all these comorbidities of type 2 diabetes, obesity, overweight, high cholesterol, hypertension, metabolic syndrome, etc. And so given the rise of all these comorbidities, we're finding that it converges on the liver. The annual cost of inaction associated with all cases of MASLD were estimated at 103 billion, and I think these numbers are certainly going up when we look at the cost of healthcare. It's now becoming the leading cause of liver transplantation in women, and I think in men as well, certainly on the rise. Widespread variation of diagnosis and care due to lack of consensus among existing clinical practice guidelines. The good news is we're getting greater clarity on all of this. And then when we look at the health system preparedness for dealing with issues such as MASLD and MASH, it's really complex. It requires a multidisciplinary team. We're not just dealing with one organ, even though we're talking about the liver, it's a systemic illness. And then on the bottom left-hand side, this particular block used to say that there's no approved treatment, and this has changed since we have Resdifra or resmetirom that's been approved for the treatment of MASH. And so we need to see now, it's still early days, but how this new approval has actually changed the landscape. Next slides, please. So I'm really excited to have Dr. Alkhouri on this fireside chat. I must admit, I've been a huge fan of his with attending all the continuing medical education at the conferences, and he's really made this complex issue, both in understanding the disease as well as the management of it, very accessible, not just to specialists, but to primary care physicians, to public health physicians, and also for the patient community. So Dr. Alkhouri is the Chief Medical Officer and Chief of Transplant Hepatology, Director of Steatotic Liver Program at Arizona Liver Health. He also has a background with metabolic health disease, together with his interest in NASH, transplant hepatology, etc. So I like to think of him as a one-stop shop for everything liver related. So definitely take advantage of this and feel free to ask him questions. Naim, welcome to this fireside chat, and we're delighted to have you here on behalf of the Fatty Liver Foundation and the patient community.
Well, thank you so much, Dr. Mistry, for having me, and thank you for the Fatty Liver Foundation for organizing this webinar. We really appreciate all of you guys trying to raise awareness about this silent epidemic. And as you mentioned earlier, now we have effective liver-directed treatments and medications that can help also with the metabolic aspects of this disease. So this is a very exciting time. And then also you mentioned that we can now diagnose these patients with non-invasive tests, determine the severity of the disease, and monitor them over time without needing liver biopsies. So a very exciting time. And again, I'm very grateful to be with you on this webinar. So let me go over a few slides that we prepared for the audience, and then let's take some questions, and hopefully we'll have a very interactive session. Next slide, please. So first, I wanted to highlight that we have a new nomenclature now. So we changed from non-alcoholic fatty liver disease to what we call steatotic liver disease. We've actually asked our patients and their families about the terms fatty liver, and they found it to be stigmatizing, and also the need to say non-alcoholic. First, the word alcoholic is stigmatizing, but also this was kind of a diagnosis you have to make after asking about alcohol consumption, when in fact we know that steatotic liver disease can coexist with other chronic liver diseases, including more than modest alcohol consumption, but also it can coexist with autoimmune liver disease and viral hepatitis. So we wanted to make a positive diagnosis. So the new nomenclature, now we have this umbrella term we call steatotic liver disease, or SLD. And under this, we have what we call metabolic dysfunction associated steatotic liver disease, or MASLD. So for our patients, this replaces NAFLD. Now we call it MASLD. And then the aggressive form of MASLD is called metabolic dysfunction associated steatohepatitis, or MASH. And this is what we used to call NASH. And then we have a new category. It's called MET-ALD. This is when you have metabolic dysfunction, but also excessive alcohol consumption. So an example will be a patient with type 2 diabetes. If it's a male, then he's drinking between 3 to 6 standard alcohol drinks a day. If it's a female, the limit is between 2 to 5 standard alcohol drinks. So again, it's a patient that have metabolic risk factors like diabetes and obesity, plus the alcohol consumption within the range I mentioned. And then we have the classic alcohol-associated liver disease. These are patients that consume more than 5 to 6 drinks per day for women and men. And many of them don't also have metabolic risk factors. We also have a new category called specific etiology steatotic liver disease, because we've known that several medications like steroids, amiodarone, can cause steatotic liver disease. Also, there are some genetic diseases like Wilson disease and lysosomal acid lipase deficiency. These are rare, but again, if there is a unique family history, if there are other, unique manifestations, it's very important to think about these rare genetic diseases that can be misdiagnosed as steatotic liver disease from MASLD. And then we have miscellaneous, such as hepatitis C, for example. If you have an infection with what we call genotype 3, that can give you steatotic liver disease. And the last category, we call it cryptogenic SLD. These are patients that have steatosis or fat in the liver without a clear explanation. I think, again, the two key takeaway from the new nomenclature is, again, we have the umbrella term of SLD, and then we have MASLD and MASH to replace NAFLD and NASH. We have a new category called MET-ALD. Next slide.
Naim, can I stop there for a moment?
Yep.
I just want to, Tiffany, on the previous slide, please. Um, so we've at the Fatty Liver Foundation have really taken this nomenclature to heart. And from a patient point of view, we actually rebranding the Fatty Liver Foundation to the Steatotic Liver Foundation to accommodate this. And we used to have a saying at medical school that the patients don't read the textbooks, our nice, neat categorization. And I think Met ALD was a really, really important categorization because the way we live our lives is with a confluence of various risk factors that result in disease rather than single disease or factor disease causation. And it's also been really important for us looking at it as sort of different etiologies with a similar patient journey. And that's the support and care that we offer our patients to the extent now that the Fatty Liver Foundation is working closely and partnering with the Sober Livers Society to actually address these diseases because of these factors. So definitely enabling for the patient community with this new nomenclature and classification.
All right. So, we know that MASLD is not just a liver disease. This is really a systemic disease that has multiple extrahepatic manifestations. So we know there is a strong bidirectional relationship with type 2 diabetes. So patients with type 2 diabetes have very high rates of MASLD and MASH, about 65%. And then if you have actually MASLD without diabetes, that doubles the risk of you developing diabetes in the future. MASLD is also associated with PCOS, polycystic ovarian syndrome, and all patients with PCOS should ask their provider about getting screened for MASLD. There's also association with other chronic conditions like chronic kidney disease, cardiovascular disease, extrahepatic malignancies. We have several studies showing association with colon cancer, pancreas cancer, even breast cancer. There's also osteoporosis or bone loss and sarcopenia or muscle loss. And these are two manifestations of MASLD. And then obstructive sleep apnea, very important also. All patients with obstructive sleep apnea should be tested for MASLD. And in fact, if you have obstructive sleep apnea and you receive treatment with CPAP, that can help decrease liver inflammation and potentially decrease the progression of MASLD and MASH. So I always tell my patients that, our job is to look at you holistically. We shouldn't be very myopic and just look at the liver. We need to screen you for diabetes, dyslipidemia, assess your cardiovascular risk, and then look at specific complications like PCOS and obstructive sleep apnea. Next slide, please.
Naim, can I ask with that, um, uh, can you comment on our understanding of the pathological basis behind all of this, given that it's quite the wide, varied organ system impact?
Yeah, I mean, I think at the core of all of this is what we call insulin resistance. And also, there is inflammation within the adipose tissue. So, as we gain weight, the adipose tissue, the fat tissue expands. The size of these fat cells or adipocytes increases. And that triggers this inflammation in the adipose tissue, release of what we call inflammation mediators. We call them cytokines, and that can trigger insulin resistance. So this adipose tissue becomes less responsive to insulin. It starts leaking fatty acids into the circulation, and these fatty acids can go inside the liver. And then it also induces a state of insulin resistance in the muscle. And the muscle is a very important organ to utilize glucose or sugar. And that's why we always advise, exercise for all our patients with steatotic liver disease. And then at the level of the liver also, you start producing more fatty acids that go inside the liver cells. Unfortunately, obesity is the root of all these bad things that happen to our patients. And with obesity comes insulin resistance, and that lead to several of these complications. We know that insulin resistance and chronic inflammation also increase the risk of cardiovascular disease, which is a leading cause of death in patients with steatotic liver disease. And also, this chronic inflammation is potentially responsible for some of the other cancers outside of the liver, as I mentioned earlier, like colon cancer and pancreas cancer. So I think it is important to recognize insulin resistance at an early stage and try to prevent these complications. And I'm a big fan of diagnosing prediabetes and then being aggressive with treating prediabetes to prevent the progression to full-blown diabetes and all the complications that come with it.
Excellent.
All
Tiffany,
right.
next, please.
So we have exciting news. I always say 2024 was a landmark year for us in the steatotic liver disease space because for years we did not have any liver-specific therapies. The mainstay of treatment was always a lifestyle intervention that focuses on weight loss and exercise, and this is still true today. But unfortunately, the success rate has been lower than we would like in our patients, and that's why we needed liver-directed therapy. So on March 14, 2024, the FDA approved the first drug for MASH. It's called resmetirom. The name comes from a resolution, res, of metabolic met syndrome. So this is why it's called resmetirom. And the brand name is Resdifra because it's the resmetirom difference for our patients, because hopefully it will actually slow the progression of the disease and potentially reverse it in some patients. So how does resmetirom works? It's a liver-targeted therapy. It targets something we call the thyroid hormone receptor beta. And basically, the idea is the thyroid hormones regulate metabolism. And, it's very beneficial to target the thyroid hormones in the liver because they can increase the utilization of fatty acids and basically defat the liver. The issue is that if you just give patients thyroid hormones, they end up with other manifestations outside of the liver, like increased heart rate, arrhythmias, bone loss. So resmetirom just works inside the liver. It targets the receptor for the thyroid hormones that is specific to the liver. We call it thyroid hormone receptor beta. And this way you get the beneficial effects without the unwanted adverse events in the heart and the bone. The medication was investigated in several phase 3 trials, and we have a large safety database that includes over 2,000 patients, and it was well tolerated with low discontinuation rate. The two most common side effects are mild nausea and diarrhea, and typically they last for 3 to 4 weeks, and then they're self-limited, and we can manage them for the most part relatively easily in most patients. In terms of efficacy, we have a large phase 3 trial called Maestro NASH, where we looked at 966 patients that were randomized to 2 doses of this resmetirom versus placebo. And we showed efficacy in terms of fibrosis regression. So going down in fibrosis, which is scarring of the liver. And this is a key message for the audience that you can reverse liver scarring. And actually, about 25% of patients were able to go down by one full stage after 1 year of treatment. So if you started at stage 3, which is pre-cirrhosis, you went to stage 2. If you started at stage 2, you go to stage 1. So this is wonderful for our patients. And then between 25 to 30% of patients had also what we call a resolution of MASH. So that means that they had less inflammation in the liver, only minimal inflammation, and no liver cell injury. These are the two endpoints that the FDA requires to approve a medication, and resmetirom met both of them in the phase 3 trial. And based on these results and the safety data, the FDA granted approval on March 14, 2024. So we actually just celebrated the first birthday of Resdifra. I was at a liver meeting with Scripps Clinic in San Diego, and we had a small birthday party because it's very exciting news for our patients. Next slide. So in terms of the latest update on Rezdiffra since the FDA approval, and now we are at the 1 year mark, we have close to 12,000 patients that are now on Rezdiffra receiving the medication. So this reflects that there is strong adoption and acceptance of the medication among specialists, hepatologists, gastroenterologists, and some endocrinologists. Also, Madrigal Pharmaceuticals shared some exciting data from a study that was an open label extension study where about 120 patients received resmetirom for 2 years, and they looked at changes in their biomarkers, including their liver stiffness that we can measure with the machine called FibroScan and other biomarkers of liver fibrosis, and shared some promising data. So this establishes two things. Number one is, the potential safety in patients with cirrhosis. Number two is potential efficacy in this population. I want to highlight very clearly that Rezdiffra was approved by the FDA to treat patients with MASH and stages 2 and 3 fibrosis. So it's not indicated for early disease. If you have no fibrosis, you just have steatotic liver disease, you're not a candidate for Rezdiffra. But also, it's not indicated for patients with cirrhosis at this point, because we have a large phase 3 trial that's ongoing now, and that will establish the efficacy in cirrhotics if it's positive. So again, I'm sharing these data because it's a very exciting development in the field and speaks to the safety and potential efficacy in cirrhotics. But this is outside of the label. And if you go see your doctor, they will not be able to prescribe resmetirom if you have cirrhosis. So we need to make this clear. We have to wait for the phase 3 trial and the FDA approval. Next slide. Another exciting therapeutic intervention is the use of what we call a GLP-1 receptor agonist. These medications are very popular now, and they have the FDA approval for treating type 2 diabetes and obesity. I think the two most effective GLP-1s that we have today are semaglutide, which we use under the name Ozempic for diabetes, and Wegovy for obesity. And then we also have tirzepatide, which is a dual agonist for GLP-1 and GIP. And this is Mounjaro for diabetes and Zepbound for obesity. So GLP-1 receptor agonists, they have pleiotropic or multiple effects. They work on your appetite. They decrease your stomach emptying, so you get full quicker. They actually work on the brain and decrease hunger and appetite. They also induce significant weight loss. And there's a downstream effect where you see actually reduction in cardiovascular disease. And we've seen this in patients with type 2 diabetes, but also recently in obese patients without type 2 diabetes. There's a clear reduction in cardiovascular outcomes. There's also a reduction in chronic kidney disease, improvement in knee osteoarthritis. So these medications can solve several problems at once. And recently at the AASLD, the liver meeting in November, the results of the phase 3 Essence trial were released. And this was a trial that looked at patients with MASH and stage 2-3 fibrosis. And we treated 800 patients for almost a year and a half. And the medication semaglutide at the obesity dose was effective in achieving both fibrosis improvement and MASH resolution. So hopefully the FDA will grant approval at the end of this year for us to use semaglutide specifically to treat patients with MASH and stage 2 and 3 fibrosis. So potentially by the end of this year, we will have 2 FDA-approved medications that are specific to MASH. So I said 2024 was a great year for us, and I'm confident that 2025 is going to be another great year for us. So I'm going to conclude here with one thing I've been preaching in 2025. We have a new message for patients with potential steatotic liver disease and for providers. Number one is a screen. Okay, I call it the 3 S's approach. So S number one is screen for steatotic liver disease. So as a primary care doctor, I want you to screen all your patients with type 2 diabetes, metabolic syndrome. And as a patient, if you have type 2 diabetes, if you have PCOS, high cholesterol, you've had cardiovascular disease, ask your doctor to be screened for steatotic liver disease. And then as number two is to stage. We need to know the stage of liver damage, fibrosis. So if your doctor tells you you have fatty liver disease, lose weight, come back in a year, that's not acceptable in 2025. You should say, how bad is it, doctor? What is the stage of my fibrosis? And this can be done without an invasive biopsy. It can be done easily with an ultrasound fibroscan. It can be done with the MRI, we call it MR elastography. It can be done with several blood tests. So again, screen, stage, and then if the doctor comes back and they say your stage is 2 or 3, you need to start treatment. And today we have Resdifra. By the end of the year, we will have semaglutide. And again, a key message is that it's not just a liver disease, it's a systemic disease. So we need to also treat the obesity, optimize the diabetes management if you have type 2 diabetes, and all of these things will help the liver as well. Next slide. Okay, well, I guess one more slide. So we have a very robust pipeline. We have so many medications in development for steatotic liver disease. It's a busy slide. I'm not going to go over every mechanism of action, but I hope that the slide gives you hope that we're not stopping with these two medications, resmetirom and semaglutide. We have several medications. A quick summary to tell you about how we think about treating the disease. We can start by targeting insulin resistance and the inflammation in the adipose tissue. And we have several medications that can work on this, like semaglutide, tirzepatide, and some other insulin sensitizers. And then we can work on the liver itself and decrease the production of fat in the liver. There is a process scientifically we call de novo lipogenesis. But basically, the whole idea is the liver can convert sugar into fat using several enzymes, and we can block each of these enzymes and make sure the liver is producing less fat. We can also work on what we call the mitochondria. These are the engines within the liver cells, and we can make them more efficient to utilize the fatty acids in the liver. And then we can also target other organs that are involved in insulin resistance, like the pancreas, the kidneys, and we have several medications we call SGLT2 inhibitors that are very popular diabetes medications and have other beneficial effects in patients with heart failure and chronic kidney disease. And we've seen some data that they may also be helpful in steatotic liver disease. And then we can also target dysbiosis and the gut microbiota. So again, several therapeutic targets. I think the key message here is that, again, as a scientific community, we continue to develop drugs, and in severe cases, we may end up using combination therapy with the two drugs only when needed in certain patients. Next slide. So with this, I'm going to hand it back to you, Dr. Mistry. And again, thank you so much for having me on this lovely webinar.
Excellent. Tiffany, we can take the slides off for a moment. So we do have a couple of questions that have come in on the chat, and I'm going to go to that as well. But let me start off by saying, so I really like the 3 S's, the screen, the stage, and then stage 2 and 3 is an indication for treatment. But there has been some controversy around the staging and what is the right methodology with which to stage. And can you comment a bit about that, Dr. Alkhouri? Because we've been getting mixed messages depending on which health system you're dealing with on how to confirm the staging.
Yeah, I agree with you that sometimes there are nuances, and every test we have in medicine have issues with the false negative and false positive results. So you need to understand the test that you are using. But I can tell you that, the vast majority of my patients, what we do, we look at their baseline labs, like the AST to ALT ratio, the platelet count, their age, and we do a very simple calculation called FIB4. And FIB4 is available online again as a calculator. And we have a low cut point, we have a high cut point, and we do this on every patient. And then in my clinic, we also do FibroScan. We call it scientifically vibration controlled transient elastography. But this is a very easy ultrasound-based test that can help you determine the fibrosis stage. And the key message is that if the FIB4 index and the FibroScan show you that you have significant fibrosis, you can feel very comfortable that the patient has significant fibrosis and you get your answer that way. You don't need to do anything else. If there is any discordance, one test is high, the other one is low, typically we resort to a third test, and we have several tests that you can use today, and they're widely available in the United States, including enhanced liver fibrosis test, ELF or ELF, and this is available to all the major commercial labs in the United States, like LabCorp and Quest. And then we also have MRI elastography. This is a special MRI. It may not be as available, but there is, more and more machines that can do this test. And there is also other ways to look at liver stiffness, similar to FibroScan. So there are some new machines called hepatoscope, Velicure, and then you can also have liver stiffness measurements on a conventional ultrasound. And then similar to the ELF test, which is a blood-based test, we have some newcomers also, including something called the OWL liver test. Another test that may become available in the US soon is called NIS2 Plus. So I don't want to make it too complicated, but I think, when it's all said and done, about 70% of patients can be staged with FIB4 and FibroScan alone. And then about 30% you may have to do another test. And that leaves only about 5% where you need a liver biopsy to make an accurate diagnosis. So I think, yes, there are nuances. No test is perfect by itself. I'm a big fan of also looking at the entire picture and understanding your patient before you interpret any test. So if a patient is older, they have type 2 diabetes, they have family history of fatty liver disease that led to cirrhosis in their father or mother, this is a very high risk patient. So when the test is high, you have to take it more seriously. If you have a young patient who's 25-year-old with no family history, no diabetes, and one test is high, you have to take it with a grain of salt and confirm. So this is what we call in medicine pre-test probability. So even before you do the test, what is the likelihood that the patient will have advanced disease? So I think, the message to our patients is that, your doctor should be familiar with at least two or three of these tests, and by utilizing them in combination, should be able to determine the stage of disease without needing biopsy in the majority of cases.
That's excellent. However, the tests that you talk about, particularly the scanning devices, etc., are not something you would commonly find in a primary care physician's office. And so when we get to that nuance and understanding that, especially when we want to get an accurate picture of staging for an indication for treatment, it's at the hepatologist, gastroenterologist level. And are these the specialists that are allowed to prescribe these new drugs or Rezdiffra in the United States?
Yes. So today, Rezdiffra is a subspecialty medication. So it has to be written by a hepatologist, gastroenterologist, endocrinologist. But I think we need to change this, and we need to change this in the near future, because at the end of the day, similar to diabetes management, the majority of these patients sit with their primary care doctors, and they should be managed by their primary care doctors. And that's why we are doing these webinars, but also we're trying to develop preceptorships and educational programs that target primary care physicians and advanced practice practitioners, and give them kind of a certification. So one of my plans for 2025 is to establish this educational program called steatology preceptorship. So, you become a steatologist. And the idea here is that, hepatology is a broad field, and you have to learn about liver transplantation and autoimmune disease and viral hepatitis and rare liver disease. But I mean, these are very, very specialized diseases, and not everyone needs to know about them to be able to treat steatotic liver disease. So the idea with steatology is that we will train the providers to understand MASLD and alcohol-associated liver disease and MET-ALD. And we teach them about the non-invasive test and how to determine the severity of the disease. And then we teach them how to treat the metabolic comorbidities, so obesity, type 2 diabetes. And then we teach them how to treat alcohol use disorders. And this way they can manage the entire spectrum of steatotic liver disease. I think we have enough patients with these conditions that this will keep a primary care physician very busy. And, once they progress to cirrhosis, there is need for transplant. Then they go to the hepatologist and they go to the large academic centers. But I think we need to do this to expand the prescriber pool.
And so that's good because then there's possibility of initiation of treatment at a specialist level and then referral back to the primary care physician for continuing monitoring, etc. Which comes to the point of monitoring then. How is it that patients are monitored to respond in their response to this treatment? Are there endpoints of treatment? I know the trials showed one stage reduction, but over time, can we anticipate two? Total reversal, etc.
Yes, so I think, when we monitor, I like to look at three things. Number one, we look at your liver enzymes, ALT and AST. And this is something we do with every chronic liver disease. And if you see a reduction from baseline, that's typically a good sign. It indicates less liver inflammation and liver cell injury. Number two, I like to look at steatosis. How much fat do we have in the liver? And it's been shown with the resmetirom phase 3 trial that if you reduce your liver fat by a certain threshold, that indicates that you're more likely to achieve MASH resolution and fibrosis improvement. So I look at liver fat with the FibroScan machine. There is a score called the CAP score, CAP, and I would like to see that one come down. And of course, this can be done with the special MRI also and other technologies. And then third, and maybe most important, is we look at fibrosis stage, liver stiffness. And this is, we measure it in what we call kilopascal units or kPa. So sometimes, providers refer to it as the kPa number. But I like to see liver stiffness come down as a sign that fibrosis is improvement. There were a few patients that improved by 2 fibrosis stages. Of course, you have to take it with a grain of salt because sometimes we worry about the accuracy of the biopsy interpretation, but this is not unheard of. In fact, with a completely different new drug called efruxifermin, which is an injection that you have to do once a week. With that drug, in one trial, we treated patients for 2 years, and actually about 1/3 of patients dropped by 2 fibrosis stages. So they went from F3 to F1 or F2 to F0. So I think we're getting there. We also have some preliminary data that even in patients with cirrhosis F4, you can potentially take them down to F3. And we have one promising phase 2 study that demonstrated this very clearly. This was significantly better than placebo. So another key message to our patients is that although we don't have any FDA-approved medications to treat MASH cirrhosis today, we have several clinical trials that are looking at this population. And I encourage you to go to a website called clinicaltrials.gov, and you can research the condition that you have. And if you have MASH or fatty liver with cirrhosis, look at the sites that are doing clinical trials for cirrhosis because these studies are global studies. Typically, they include 200 to 400 sites, and you might be surprised that you may have a research center close to you that is doing this study. And I think, I highly encourage patients with cirrhosis to look into clinical trials because, again, we don't have any FDA-approved medications, and clinical trials can be a very good way to receive excellent healthcare.
That's great. And let me also make a plug for the Wellness League that the Fatty Liver Foundation has, because we have a lot of resource about clinical trials there and also links where you can get onto these sites. So I think we have answered the question about efruxifermin that was raised together with the reduction in the staging. I do want to point out this question, which is, can Ozempic assist in treating fatty liver? And it's interesting you mentioned the steatosis component as well as the fibrosis component. And is Rezdiffra addressing both, or does one need to add something, especially if there's underlying obesity, something like Ozempic?
Yeah, so semaglutide in the Essence phase 3 trial was able to actually address both, MASH, so steatosis, inflammation, liver cell injury, and also fibrosis. So this is a key message because in earlier studies, we didn't really see a clear signal on fibrosis with semaglutide, but now that we have a very large study with 800 patients, we see a clear signal on fibrosis. So I think semaglutide addresses many of the underlying comorbidities in patients with MASH. We know that our patients, about 80% have obesity, 45% have type 2 diabetes, two-thirds have hypertension, and also about three-quarters have dyslipidemia. And all of these will benefit from semaglutide. So I think, in the future, we're going to see semaglutide and resmetirom used as first line in some patients. But then you're going to see that we are adding the second medication to help in selected cases. So, for example, if a patient has uncontrolled type 2 diabetes with a high body mass index and they have stage 2 fibrosis, I may start them on semaglutide and then reassess in 6 to 12 months. And if I see that they're losing weight, the diabetes is better, but the liver is not improving, I may add resmetirom to it and keep them on both medications because you don't want to lose the beneficial effects from semaglutide, but also you want to target the liver with liver-directed therapy. I may also have patients that have been on a GLP-1 for a few years to treat diabetes, for example, but yet they still demonstrate evidence of F2, F3 fibrosis. And these patients, I would definitely add resmetirom. There are some patients that do not tolerate GLP-1 agonists. So just yesterday, I saw a patient in my clinic with F2 fibrosis, and I offered him both options. And he's like, I've tried GLP-1s. I just had severe nausea, could not stay on it, and I don't want to go through this journey again. And I offered him resmetirom. I think a key message with the GLP-1s that you have to titrate slowly and work with the patients to make sure that you can get them to the highest tolerated dose. But unfortunately, there are, many patients that just cannot stay on these medications long term. So I think, both medications complement each other. I see synergy, and we've seen actually good efficacy when we added resmetirom on a stable GLP-1 agonist.
So I think in the world we live in, we've gotten quite accustomed to lifelong therapies, right? Diabetes, cholesterol, hypertensive management, etc. So there were concerns about whether Resdifra would be a lifelong therapy. And has there been any assessment on people coming off the drug? It's still early days, but certainly with Ozempic, there was a rebound of obesity or putting on weight that was lost with it. And are there any concerns, and what sort of other strategies, maybe non-pharmaceutical, do patients need to look at as well?
Yeah, no, that's an excellent point. And as you said, with diabetes, with other chronic conditions, we don't stop the medications when we see improvement in blood sugar or hemoglobin A1C. We continue because we know they're going to rebound. And we saw the same with obesity and semaglutide. So the idea is that with, MASLD, MASH, we need to continue the treatment. The only exception will be if the medicine is not working, obviously, or if the patient implements a very intensive lifestyle intervention and they lose significant amount of weight, and they ask me to go off the medication. I think if I see that there is enough improvement in liver and now they have minimal or no fibrosis left, I may give them a chance to go off, but then you have to monitor very closely to make sure that the disease is not rebounding and that you've lost all the gains from the treatment. So you may consider this again, but my approach is going to be that I would treat at least for 2 years, and then I would only do it in patients that demonstrate significant changes to their lifestyle and show me that they've lost a significant amount of weight. And then even when I stop, you have to monitor for recurrence of the disease. And then you can resume treatment if you see recurrence.
That's excellent. I just want to refer specifically to some questions now. And we talked about glucose sensitivity Any role of metformin in fatty liver, MASH cirrhosis, or used in conjunction with these drugs?
So metformin is one of the oldest diabetes medications, and it's actually well tolerated. Unfortunately, when we did studies looking at these biopsy endpoints like MASH resolution, fibrosis improvement, it was not effective. However, we have studies showing that patients that take metformin for diabetes, it might be protective against liver cancer in the context of MASH. So I encourage patients with type 2 diabetes to be on metformin or to stay on metformin. But again, we cannot recommend it as a treatment for the liver disease itself. I think for the longest time, metformin was a first-line treatment for diabetes. However, now I think we're shifting towards more GLP-1 agonists, especially in patients at risk for cardiovascular disease, and SGLT2 inhibitors, especially in patients with underlying heart failure or chronic kidney disease. So again, I think it's a good medication. Since you asked, I divide diabetes medications into three categories in patients with MASLD. I call them like the good, the bad, and the ugly. And the good ones are the GLP ones, of course, the SGLT2 inhibitors. The neutral ones that don't really help the liver are probably the DPP4 inhibitors and metformin. And then the ugly ones that I try to avoid in my patients are sulfonylurea and insulin. They actually can potentially make steatotic liver disease worse. So if you are a patient on a glipizide, talk to your doctor and say, why am I on glipizide for my type 2 diabetes when there are much better medications for, fatty liver disease, steatotic liver disease, and type 2 diabetes? I think the only reason today for anyone to be on glipizide is insurance issues. Otherwise, we have much better options to treat type 2 diabetes.
That's great. There was a question on someone was diagnosed with a FibroScan or staged. They were started on Restifra. When should their next scan be?
Excellent question. So I like to get my baseline, and please don't just look at one number on the FibroScan, which is the stiffness or the KPA. So, make sure your doctor is checking your ALT, AST, the liver enzymes, and you are looking at the fat number, the CAP score, and you're looking at the liver stiffness number. So all three. Typically, I do all of these at baseline, and then I do them at 6 months, and then I do them at 12 months. And then I look at the totality of the data. I know some of the guidelines recommend that you wait 12 months, but I think with the variability we've seen with the FibroScan, it's better to have basically three measurements, and then you look at the totality of the data. If your liver enzymes are significantly lower, if your CAP score is much improved, and the liver stiffness is still the same, I would continue because it can take longer for liver fibrosis to improve. However, if you see worsening and the liver stiffness and the enzymes are the same, then maybe at the 1 year mark you can stop. But this is my approach. So I check at 6 and 12 months with the FibroScan and the liver enzymes.
So when we attend the liver meetings, we all have our chance to be a guinea pig and go for different scans. And for myself personally, I found that there was a 20 to 30% variance in the various scans that I tried. And there was one question here. I've had two FibroScans with very different results. How can my doctor be sure about my condition? And I think you address this really well. Look at the whole patient, correlate with blood tests, understand risk factors, family history, etc.
Yeah, and I think the other thing is to look at the FibroScan in its entirety, not just at the numbers, okay? So there is experience that comes as you do more and more FibroScans. With FibroScan, we typically do 10 measurements, and what we provide to the patient is the average score for both the liver stiffness and the CAP score, and you have this variability, and actually it's on the report. It's called interquartile range or IQR. And the lower this IQR, the better the quality of the scan. And then, as someone who's been doing this for a while, I also look at the images that you get with the FibroScan. So you actually get 10 images, and you can see these, we call them shear waves. These are the waves that we measure their speed or velocity to determine the liver stiffness. And you can tell if it's a good quality shear wave or not. Sometimes you can see the shadow of the ribs, and that can tell you that the test may not be accurate. So I think, just again, having someone with the expertise to interpret FibroScan is always a good idea. And then realizing that, this is an easy test. So if you have two results that are kind of, very discordant, maybe you go for another FibroScan and, have a tiebreaker, or ask your doctor to do another test for liver fibrosis, like MRI, elastography, or the enhanced liver fibrosis test, and that can be the tiebreaker also. So FibroScan, again, is great in about 70% of patients, but we struggle with it in about 30% of patients. And this is when additional tests are necessary. And I think if all fails and you're not comfortable, a liver biopsy and knowing exactly where you're at on the disease spectrum is better than not taking any action, because if the biopsy shows stage 2 and 3, then you will qualify for treatment.
That sounds good. So the next couple of questions actually deal with the issue of access. And so people living in rural areas in the United States whose doctors, primary care physicians aren't well versed with fatty liver disease or steatotic liver disease, and access to a hepatologist or gastroenterologist may be far away. So at the primary care level, as well as not in urban centers where people don't have access to people like yourselves. What are the options for patients? Are there online tools available? Are there virtual consultations? Um, how do patients go about finding help?
Yeah, I mean, I would say most large hepatology GI practices they have a televisit option now, and we've implemented this on a large scale since the COVID-19 pandemic. So we offer this, at our offices in Arizona. So that would be one way to get to the expert without traveling long distance. Sometimes with the testing, again, we have some blood-based tests that can help risk stratify these patients. And the other thing is, we talked about FibroScan machines not being available, but it is very important for all the doctors and primary care physicians on the call to ask their radiology colleagues if they have a way to measure liver stiffness, because you might be surprised. I mean, liver stiffness is available on conventional ultrasound machines. So the most common ones we see are like the Siemens ultrasound, Philips ultrasound. They can all measure liver stiffness. So just check, and you might be pleasantly surprised that you can determine this not on a FibroScan, but on an ultrasound that can measure your liver stiffness. So we have ways to overcome this. There are also e-consults, as you mentioned, and these can be done at large academic institutions where you can fax your entire, medical records, and they can provide you with an expert opinion on your condition. And sometimes they offer you also to come in person if needed, maybe for patients with cirrhosis and other complications.
So Tiffany, who's helping coordinate this call on our team at the Fatty Liver Foundation, is actually working with on our Wellness League site. We have a find help function where patients can go on and enter their zip code, and it will give them a multidisciplinary set of services, everything from nutritionists, but also hepatologists, gastroenterologists, etc., as well as locations where we are now mapping wherever FibroScan and elastography, etc., is available in the United States. So that's certainly a function that people can look at. I will be remiss if I did not ask, what happens when someone has met ALD and comes to you, given that the indications haven't been quite clearly expressed for met ALD?
So that's an excellent question. And, the estimates now that if you look at the United States population, probably around 2 to 3% of adults may have met ALD. So definitely less common than your typical MASLD. We estimate probably 35% of adults have MASLD, but this is still a lot of people. And what we learned from the Maestro NASH trial, we actually identified a group of patients, about 10% 2% that, they self-reported that they don't drink excessive amounts of alcohol. But when we did some alcohol tests, the test came back positive that maybe they underreported the amount of drinking they're doing. But the trial did not exclude them because we just relied on self-reported alcohol intake. And they're treated for the 1 year duration. They had the biopsy, and when we analyzed their data separately, they had the same response on MASH resolution and fibrosis improvement. So it's not in the FDA label. The guidelines don't recommend that you treat MET ALD. But again, I was very involved in treating this cohort of 75 patients. I saw the same results. So this is, up to your physician and their comfort level. But again, it's outside of the label and it's outside of the guideline recommendation. The way I approach this, obviously, they have two conditions leading to liver damage. One is the alcohol, so we need to talk about decreasing alcohol consumption. Some patients can do it on their own, but some patients have alcohol use disorders, and we have several treatments for that. So make sure that your provider is able to give you the medications you need to decrease your alcohol consumption. And then we treat the metabolic risk factors. So typically these patients have diabetes, obesity. So can we help them? And we have new evidence that GLP-1 agonists can actually help with both obesity, diabetes, but also decrease cravings for drinking. So we may be able to kill two birds in one stone. I think after we do all of this, if we feel like the patient still has, F2, F3 fibrosis, then again, resmetirom has shown some promising results, but still relatively small sample size, and we need a dedicated MET ALD study before we can recommend it in the guidelines.
Um, uh, Something that did come up at the liver meeting on a couple of panels was questioning the 2 to 3% prevalence of MET ALD in the United States. And I think we need to certainly get a bigger picture because we all believe it to be much higher than that. But it is promising. I think the last question I'll take from the question and answer box, and it was an interesting framing of it. Can liver cancer, hepatocellular carcinoma, be considered stage 5? Is it part of the progression, or is it a new disease altogether requiring a different management?
I mean, it's definitely, an event that we consider a significant event in the journey of patients with MASH. And, it is considered kind of a decompensating event because it will really change how we manage the disease. When we talk about fibrosis, most of the systems we use now, we have 4 fibrosis stages, and the last one is cirrhosis, stage 4. So we don't call HCC stage 5. But again, it indicates that the disease progressed to a new phase that will require completely different management. Of course, the vast majority of HCC cases happen in patients with MASH cirrhosis, but unfortunately, we've seen some cases develop in patients with less advanced fibrosis. So this is something to keep in mind. It's not common. We don't screen for HCC in every patient with steatotic liver disease, but in my clinic, we screen all cirrhotic patients and anyone with stage 3 fibrosis. And the screening for liver cancer should be done with imaging. Typically, we alternate ultrasound and MRI every 6 months. And then we also do a blood test called alpha fetoprotein. So if you have MASH cirrhosis, please, please, please make sure you are followed by a specialist and make sure you have imaging of the liver and a blood test every 6 months, even if you feel great and you have no symptoms, because the risk of liver cancer is about 1 to 2% every year in patients with cirrhosis.
So I can't believe we had time already. The key takeaway slide has been up, and forgive the military analogy. What we have learned in medicine is that there's no single bullet, silver bullet, magic cure for anything. But certainly having a drug approved for this adds to our armament of like a comprehensive, holistic, looking at our patient as a whole response to managing this complex disease. So thank you so much. Dr. Alkhouri, I'm going to let you have a last word to our patient community, recommendations, anything you'd like to say to them.
Well, first, I want to thank you and the Fatty Liver Foundation or the Steatotic Liver Foundation for organizing this webinar. And honestly, I'm very impressed with the several things that you mentioned, especially how patients can find providers that can take care of their, disease, and prescribers meet their own stage, the severity of the disease. So, very nice to hear. And I would like to tell our patients that, you need to be proactive. We've been educating about the risk factors. So again, if you have type 2 diabetes, coronary artery disease, PCOS, make sure you are asking about being screened for steatotic liver disease. And then if you've ever been told you have steatotic liver disease, make sure you know the stage of your disease, okay? And then if you have stage 2, 3, know that we have a couple of options for you today, and we have many more coming in the near future. I think by the end of the decade, we will have probably 6 medications that are FDA approved. So educate also your community. So if you have family members that have type 2 diabetes and they've never been screened for steatotic liver disease, talk to them. And again, many patients were told maybe 5 or 10 years ago they have steatotic liver disease, and they're told that there is nothing that can be done about it besides a lifestyle intervention. But there's a lot that can be done today. So many things have changed. So spread the word. The fact that you attended this webinar is a good sign that you're interested, and we are relying on you because we need all of us to help with this epidemic.
Excellent. Thank you so much for this input, and thank you to our patient community. This video will be made available on our YouTube site, and go out there and be steatotic liver disease evangelists, and we'll see you at the next webinar. Take care, everyone. Thank you.
Thank you.